going to talk about the ISR and essentially atherectomy devices. I want to thank BK and the organizer for the invitation. So these are my disclosures. So we know what ISR is, essentially smooth muscle cell and hydrated collagen matrix. And if you look, you think about it, it's almost 60 to 80% of what you're seeing right now in this case actually is all water. The way angioplasty typically work is by compression and decompression, and that's how you probably gain most of your minimal luminal area with angioplasty alone. The problem is, however, if you just leave that stuff only for half an hour, just have a cup of coffee and come back, you will find out that you lost about 30% of your lumen. So it really re-expand pretty fast. Like we say, so in this case, most restenotic tissue are a combination of thrombotic and restenotic, especially the Tosaka 3, which are the total occlusions. And red blood cell and paclitax cell don't like each other very much. In fact, in terms of absorption, the red blood cell absorb paclitax cell very, very quickly. And the more red blood cell you have, the less paclitax cell is going to be available to the vessel wall. So the choice of your device is important, not just taking care of the scar tissue, but also removing a lot of the red blood cell to allow more of that drug to penetrate the vessel wall. So we know that FEMPOP ISR, occurs very frequently, almost up to 49% of cases at 2 years. And the treatment with the angioplasty is not very good. In fact, patency can range between 28 to 37% only at 1 year. And PTA currently is just simply not an acceptable option for treatment. So we have a lot of treatment available now in the US. The Excimer laser that is currently being used by Dr. Adams in this case, that's based on the Excite-ISR trial. The 1 year freedom from TLR, however, I want you to see this is only 50% when you have no drug-coated balloon. Now, these are long lesions, 19.6 centimeter. The French registry with the Rotarex, 1 year freedom from TLR was about 80%. Mind you, there was DCB used in this, about 1 in 4 cases. And the Orion laser is also approved for ISR, based on the XPAD 03, but there was only a small number of patients that were included with ISR. But interestingly, the 6-month freedom from TLR in this one was 100%. DCB was used, however, in about 60% of these cases. Of course, drug-coated balloon, the Impact and Lutonix, were approved for this, and the Viabon stent. Atherectomy was CE marked, but not officially approved in the US, is the JetStream, based on the JET-ISR trial and other data, and the Pantheris, which has a 510K application submitted to the FDA. The data from Viva just recently in the InSight trial showing a freedom from TLR of 89%, about 13 centimeter lesion length. So we know the Excimer laser was approved based on the Excite-ISR study, 250 patients, 2-to-1 randomization, about 19 centimeter lesion length, 1/3 were totally occluded, and there was superiority when it comes to target lesion revascularization, patency, and less bailout stenting. However, just if you look at those Kaplan-Meier curves, you can see very easily that there is a sharp drop in the freedom from TLR and patency after you cross that 6-month mark, almost 40 to 50% loss right there at the 1 year mark. However, interestingly, the longer the lesions, the more effective the combination treatment of laser and angioplasty compared to angioplasty only. The JET-ISR Registry was a registry that looked at the JetStream. It was one of our registry of 60 subjects, core lab adjudicated, used a more of a comparator arm based on the PTA arms of the 3 randomized trials of the ISR study, Excite, Reline, and FAIR. And there was 10 sites in the US looking at TLR as well as looking at patency. And you can see long lesions were also enrolled in this. A lot of diabetic, 46.7%. There was a small number of limb ischemia patients. The majority were claudicant, but CTO was in 55% of the cases. The lesion length was 19.8 centimeter. The treated length was 22.6 centimeter. And you can see the acute procedure results were excellent. With the post-adjunctive stenosis was 26%. And the data showed, at least at 6 months, the TLR, if you look at 21.4% proportional TLR, the 95% confidence interval upper bound, 32.4% remain better than the performance goal of 37.9%, showing that it does work, at least compared to the historic control, it's better. Patency, however, was not very different from the laser. In fact, if you look at 12-month, the patency was only 51.7%, which is not very different from the 56.4% the Excite-ISR. Mind you, however, the JET registry did not use DCB also. So that's another thing we need to keep in mind. The Rotarex and FEMPOP ISR, this is the French registry, 128 patients, large number of limb ischemia patients, 51%, CTOs were about 60%. However, additional stenting was carried on in 66% of those cases, which is extremely unusual. You know, if you can see in the Excite-ISR was only 6%, you know, in the JET-ISR was only 10%. So this is excessively high, and there was a significant use of DCB. However, the results were good, and the TLR was only 19.5% in this setting. So let's put all this stuff together. If you look at Excite-ISR, Jetstream ISR, JET-ISR with no DCB, you can see the TLR rate is very high at 1 year, ranging between 41.5 to 47%. With the Rotarex, shorter lesions, higher stenting, and DCB use, you know, it was about 19.5%. The Reliant trial was 20%, but you can't really beat the DCB alone. You know, you can see that the TLR rate remained less than 10%, you know, in these long lesions. By the way, these are all long lesions, you know, ranging between 19 to 20 centimeter. So this is the drug-coated balloon data in general, and you can see it's all excellent except for one trial, the Pacuba trial with the freeway, you know, balloon showed a high TLR rate, but the others were really very good. However, the problem with drug-coated balloon is after this first year, you start seeing a sharp decline, you know, in the freedom from TLR. And in fact, by 3 years, you're not different from regular angioplasty. And this is based on the, trial, you know, that showed in a randomized fashion that your TLR rate can reach almost up to 40% with DCB at 3 years. And this data just got presented at Viva, at, you know, just about 2 weeks ago. And you can see that the TLR rate that started at 7.3% at 1 year with the Impact Global now is 42% at 5 years. So we know there is a lot of loss, you know, that we see, and the combination therapies start to make a lot more sense. And this data is from Gandini's, you know, that showed that the combination of laser and drug-coated balloon versus DCB alone showed clear superiority when it comes to TLR, you know, as well as amputation rate, where the combination really was superior to just using DCB alone. And that's really important. So it's not enough to do DCB on the long term. It's not enough to do atherectomy. We really need to have a combination therapy. This is a real-world data, you know, that showed that the laser plus DCB in 112 retrospective patients, a lot of CLI and a lot of Tosaka 3, 24-centimeter lesions, you know, that you can see the proportional free of reocclusion was significantly higher than the laser alone. And you can see the TLR also was significantly less, you know, with the combination therapy than just the laser alone. This is data from the Rotarex combining, you know, the DCB along with the Rotarex, and you can see that the freedom of clinically driven TLR was 89.7% at 1 year, and the primary patency was 86.2%. Again, you know, telling us that the combination is working. And what about the combination long term? You know, this is data that came presented at Link a couple of years ago, showing that the freedom from TLR with the combination is about 70% at 5 years, which really is remarkable when you compare that to some of the historic control we see only with DCB only or atherectomy only. So I think, you know, we're having some better long-term data, better acute data when you combine those therapies. So atherectomy is more effective than PTA, but the choice of the atherectomy device, whether you use your laser, Rotarex, or Jetstream, probably similar TLR rate when you are actually not using DCB. Comparative data among those devices obviously does not exist at this point. The choices, I think, of the device really relies on the operator experience and what you got in your lab. DCB is likely to be more effective than just atherectomy alone, but the combination is really the most promising at this point, and that's really where we need to start focusing our randomized data, you know, to try to get this more conclusively, you know, for our operators. Thank you.